It's with great pleasure that I introduce Dr. Michelle Bull. Michelle is a chartered physiotherapist and also an NHS transformation manager, which is, I think, a busy job. There's a lot of transforming going on. Michelle has extensive experience supporting people with ME and long COVID. She's co-founder of Physios for ME, which for those of us living with ME within our families or ourselves is a very well-known organisation that's kind of come onto the scene in the last recent years and has gained a huge amount of kind of reputation, positive reputation. She's co-author of A Physiotherapist's Guide to Understanding and Managing ME/CFS. She holds a doctorate, is active in health research, and is based at the Royal Surrey NHS Foundation Trust, leading what's known as the Frailty Academy. But Michelle, like all of us, is passionate about improving care through evidence-based priorities, through education and through transforming systems. And really, this is the moment to be talking about service transformation, as we know that there are discussions going on about the future of the long COVID services all around the country, and there is work going on with the government about transforming the delivery of services for people with ME/CFS. We are absolutely determined that we move away from this idea that somehow a non-medical response of actually kind of doing various homegrown group work programs is enough. We know that people living with these conditions have got a whole set of symptoms that potentially are treatable, and we need to get good quality, clinically led medical care for people to be able to access to improve their quality of life. So Michelle's also just been at this amazing conference in Norway, and she's going to tell us some of the kind of takeaways from that as well. So without further ado, I'm going to hand over to Michelle. Thank you so much, Michelle, for coming and joining us today. We really appreciate it. Thank you.
So going to talk a little bit about ME and long COVID, but just literally sort of at a very high level. A bit about PEM, and focus a bit around what I think good symptom management looks like. So picking up that point that we just made in the very kind introduction, and I should say thank you so much for having me here to speak, around what should good look like, and then feed in a bit around service provision and what it looks like and how we can change it. The picture on the right is from, I went for a bike ride when I was in Norway. So this is a bit of a picture from Norway. And what I've tried to do is weave through the Norway slides as I'm going, weave through the relevant information from Norway, because I think that makes more sense than leaving it at the end. And then a little bit at the end around what next. And just to say about the advice that we're giving, it's not intended to be an individualized, personalized advice. It's just to be some things that you might want to take forward and discuss. So it's going to be tight to get it all in. So I will whiz through on some things, but I'm happy to take questions afterwards. So I don't really need to go into detail about the definition of ME. And again, with long COVID, it's a very similar definition, but I tend to focus on the patient-led definition at the top end around that prolonged condition. But again, like the ME slide, it's multi-systemic and it affects us all. The World Health Organization, I think, definition is a bit more dry. But for today, what I'm really sort of focusing on is with long COVID, we also know that there are people who have, they can have organ damage through like damaging their cardiac tissue. We can have damage through other things. And so, what I'm focusing on here is the ME subtype of long COVID, and particularly focus on PEM as well. So that's just to set the scene. And I also just wanted to very briefly mention about fibromyalgia, because I think it's really important. I know there's people in the group who are from fibromyalgia, and the main point is to recognize that they coexist, but they're diagnostically different. But PEM trumps everything over and above. If you've got both, and PEM is the thing that we need to think about when we're doing anything. The key points for us really, it's multi-systemic dysfunction. We've got those common symptoms that we've talked about around post-exertional malaise, cognitive dysfunction, and these symptoms are often fluctuating and unpredictable. Now, here's my first take-home point from Norway, and this was the bit that I absolutely got really excited about. So this is from Rob Worst's group in Holland, and they basically took people with ME, people with long COVID, and they took skeletal biopsies, and they also compared these with people who were on bed rest for 60 days. And fundamentally, although exercise capacity in both groups was similarly reduced, the skeletal muscle structure and function changed, was different between those groups. So in other words, deconditioning is not what we are talking about. We all know that, but now we've got some hard science that's proving that. So for me, this was quite an exciting bit of research that came out, and that was shared in a preprint. So I've got all the references on here, so you can look them up. The other bit that was shared from Norway that I think was particularly exciting was this slide, and I have told Rob that I've grabbed them. So if you look on the box on the top, you've got the controls, and you can see these tiny little dots here are the lumen of the capillaries. So that's basically where the blood flows through. And then long COVID and MECFS underneath is you can see it looks different. And actually, if you look at this picture over here on the right, this graph on the right, the radius, it shows that there was no radius. The difference between long COVID and MECFS is actually there's no link between the controls. There's no crossover. So this could potentially be a biomarker. So that is really quite exciting, I think. So again, watch the space from work coming out of Amsterdam. We all, I'm sure, in this group really well know about PEM and know that it comes delayed. It doesn't just come out of physical activity, and it looks different for everybody. I think that's really important. That's why I like the work cloud, because it sort of sums up sort of the whole complexity of PEM. And why does everything that we've talked about so far matter? Well, because traditionally we base our model of rehab on deconditioning, but we've seen these abnormal physiological changes in exertion, and now we're actually seeing the difference in the muscles, so we have to do it differently. And this is what I believe are our key principles for how we do rehab and differently, and how we support people differently. And no surprise, that's there loud and clear in the NICE guidance. But and again, the evidence that is starting to come out now from the physiologists is amazing, because it's supporting that. Now, I put this slide up because we quite often hear that people think there is no place for physiotherapy in people with ME. And absolutely, if we're talking about rehab like this, I would agree with you, unless it's very, very specific and very, very tailored. And we might touch on that later if we have some time. But my theory of rehab is very much takes a very different view. And this is a model that's come from oncology. It's over 40 years ago, my friend told me when I checked in with her again, and I was like horrified. But actually, for me, it really sums up when anybody is working with people with ME or long COVID, is we need to be thinking about those different strands. It's not just the restorative, ideally trying to get somebody back to as much function as possible, but being able to support them in the position that they're in. We do have things that can offer, and we can help. And when we're talking about palliative, we're not necessarily talking about end of life, we're talking about symptom control as well. Sorry, there we go. So what's the role of us as physios in any decent service? It should be around respecting PEM, screening for PEM, focusing on energy management, symptom reduction. I'd actually argue that this should be the role of any health professional, but I recognise that we're probably quite a long way off that, and this is my ideal. I am setting out where I think we should be. And I also think it's very much around working in partnership with, and I use the word patients because I'm talking about service provision, so apologies for that. But also around advocating and educating. And I think a lot of what we do is around educating other health professionals and explaining why the traditional approach might not work and why things need to be different. So what does good symptom management support look like? I can't touch on everything. I will whiz through a few things. And again, I will share some things from Norway as we go. Energy management, I think one thing that's really interesting was that everybody has a different understanding, and some people are using this definition in a way to support the perhaps a more traditional approach. But it's basically in NICE, it's very clear. It's about how it involves you managing your activities, staying within your energy envelope, and that energy envelope is something that doesn't increase your symptoms. I think one of the things, and I'm sharing this with you because I think we all collectively have a role in how we educate people, is and this might explain why some of the conversations we have is, as physios, we're very used to the bottom approach to pacing, the quota contingent pace, where we say to people, and certainly when I worked in cardiac rehab and cancer rehab, I'd be saying, right, the first thing I want you to do is to go out for a walk every day. And then I want you to increase your walk to 15 minutes every day. And then I want you to walk more briskly. However, that's not what we're talking about with long COVID and with ME. We're talking about this symptom contingent pacing. So basically making sure that we're not triggering our symptoms, making sure that we are actually conserving some energy to help move things forward as well. So pacing. You will often hear people talk about the 3 Ps for pacing. I have added a fourth, which is around pleasure, because I think it's the things I would say about pacing is that it is really hard work. It is not easy, and it is not a simple thing to do. It sounds really simple. I can see people online nodding, so thank you. It sounds really easy, doesn't it? To say, oh, just pace, you'll be fine. It is not at all. And it takes a lot of time, energy, and effort just to do the prioritization piece and the planning piece. But actually, it's really important to try and think about some things that might bring you pleasure as well. The one thing I use particularly for children is quite often there's a lot of focus on them going into lessons at school and being taught, and forgetting about the fact that actually just spending time with their friends is equally important. I mean, I think that's important for all of us, but particularly for young people. So there's a few examples on there around, how you might want to pace or plan. And, we quite often talk about, cook once, eat twice, by freezing something. But very much, I tend to start with the planning and say, right, what does this week look like? And what are you going to come back with? I can see a few things popping up on my on the chat, but I'm not going to touch anything on the screen and try and read them after the dramas from before. So I'll come back to them at the end. So I did think somebody talked about, just saw something up about any apps. So just talk a little bit about pacing with a heart rate monitor. I think basically there isn't very much evidence about it. When we started looking at it, the initial case study was from the Workwell colleagues, Todd Davenport, in 2010. But we were hearing lots of positive feedback from people who'd started using it. So we thought, let's investigate into this. So we carried out our own survey. And the overwhelming benefits were that people found it helped them because it helped them identify what caused their PEM triggers. It gave them real-time feedback. And it helped also find more energy efficient ways of doing things. So if you were standing up to do something, if you sat down, did it use up as much energy? And also really important, it raised awareness and it validated things with other people. The negatives tend to relate to lack of support from carers and sadly from us as health professionals, and some of the practicalities. And quite often we hear people saying the watch strap irritated my wrist, or I couldn't wear it for a long period of time. And then these two on the bottom fascinate me because people describe them as negatives, but actually that's pacing. It's telling you that you're doing too much and stop if the alert's being triggered. So there's something about really how do we explain pacing to people and saying, you probably need to do a lot less than you anticipated. So for me, I think that's really fascinating that people saw that as a negative. And for us as professionals, we need to be able to give people the right information so that they understand what pacing really involves. So this is the information that we use at the moment. And the idea behind pacing with the heart rate monitor is that you're looking to try and keep yourself below your anaerobic threshold. So that's when you switch from using oxygen and switch into using your body's ATP and other energy sources. So we want to keep you below that. And that's been the theory about how heart rate monitoring works, is that we're working off that because when we've looked at CPET tests, so that's a cardiopulmonary exercise test, that's been where that threshold has been. We've started the work from the States basically says to calculate your average heart rate over 7 days and then set your upper rate at 15 beats per minute. Above that resting rate. So none of this take your age and 50% or 75%. And actually it is 15 beats per minute isn't very much. And if you have something like POTS, it might swing initially, but we allow it to settle down. So we use this as a sort of monitoring and a starting place, and use that to see how we're getting on. And I can see a lot of people chatting about using Visible and really positive feedback, and I will come on to that in a minute. So here's some more exciting advice, research that they shared in Norway. So the top is some of the findings from David Petrino around Visible. And I should say that they are putting the lectures from Norway online as well. So you will be able to go in and find them from there. But I thought I just wanted to bring special highlight to these. And what they are thinking with the Visible stuff is that they are getting to a point where they can identify that you are starting to deteriorate probably before you even do crash. So that will be a really exciting way of being able to pick that up. And then along the bottom are some screen grabs that I stole again from another of Rob Worst's pieces. You can tell I'm a bit of a fan. And he was looking at heart rate variability, and so that's basically what you want with your heart rate variability, is you want it to be higher rather than lower, because it means you're able to cope with stress better. That's a very simplistic explanation, and I've seen there's a bit of chat going on, and we can come back on that. But basically, they were looking to say, actually, if we keep below that anaerobic threshold that I talked about, the VT1 that is described on here, does it help us with pacing? And absolutely yes, it does, was what they found, is that heart rate variability, if you keep it below the that anaerobic threshold, that you're going to get less PEM and better recovery. So really exciting to see that kind of the work we've been doing on the ground in reality is starting to be backed up and reinforced by research. So the other thing I wanted to talk about that I don't think gets talked about enough is cognitive dysfunction. Basically, I think we're all really aware of brain fog, and of the, I think brain fog sort of diminishes it as how serious it is, but it affects our memory, attention, how we communicate, all sorts of things. And actually being cognitively fatigued is as limiting as physical fatigue. And I think any decent service should be focusing on cognitive dysfunction as well. And just going to very briefly touch on this. So you may have seen this information, you may have seen our trial that we did a while ago, where we basically did a CPET test, but we took it to people's own home. And we tested people with a range of normal everyday activities. This is Karen, one of the other physios for me, with the mask on. Basically we got people doing some really simple things. We tested them in lying, sitting, and also going up and down stairs if they could. We had people with severe ME and with not severe ME, milder. And actually what we found was that when we got them to do the cognitive test, this is what caused the largest number of participants to exceed that anaerobic threshold, which is really interesting because you don't feel that you're working hard, do you, when you're just sitting there trying to do some maths? But actually on your measurement of sort of what's going on in the background, you absolutely were. So it is really important that we think about cognitive activity. And cognitive pacing is therefore something that I think we need to work a bit better at, being sort of helping people work through. So just like with physical activity, break it into smaller tasks, have rests, thinking about stimulation. So for example, being in a room at the moment for me with my headphones on, but with separate conversations, that's extra stimulation. If you have bright light, if you have lots of noise, even sitting in a car, you've got constant light flashing past you. allowing extra time for people to respond or for you to respond, recognizing that there might be some silences while you just allow somebody to reply. But also important, I think, is around using memory aids, not just to remind you of a time to do something, but when you are doing something to remind you to stop. Because quite often we hear people who say, I lay down, I read my book, 2 hours later, I got so engrossed in it, and 2 hours later, then the 2 days later, I really suffered with it. So I think it's important to use the alarm to help you pace as well as to remind you to do things. And then physical positioning. So can you do sit instead of standing? Can you do it in sitting with your feet propped, lying down with your head supported, all these things. And if anybody wants to read a fantastic paper, this is by 2 OTs who have long COVID themselves. And it's a really great paper. It's not an easy read. I had to read it about 3 times, but it actually goes into a lot of information about cognitive pacing. So we are whistling through the symptoms. The next one is around sleep. And I think sleep is a big thing. And I put sleep hygiene is often insufficient. I hate the expression sleep hygiene, if I'm honest. So what do I think supporting sleep should look like? And I gave this presentation in Norway and said, put this exact slide up and said, this is what I do, is I focus on the daytimes, not on the night times. And I focus on getting really good pacing working during the day, managing sensory input, supporting better rest during the day, making sure that people are having rest. And also teaching them relaxation exercises so that if they can't get to sleep, they can at least go through those processes. We presented twice in Norway, and at the second presentation, Rob shared this information, which I thought was particularly exciting. So basically what it shows is that, looking at the heart rate variability again, if you exercise over PEM during the day, you will get sleep disturbance. So the evidence is backing up my theory of what I was seeing in clinical practice. But for me, that's great. We're now starting to get that really good understanding of what we should and shouldn't be talking about. Okay, whistle stop tour. Apologies, there's lots of information, but I wanted to try and cram it full of so much stuff. So autonomic dysfunction, we know we have orthostatic intolerance and POTS. Not going to go through those in detail because I want to talk about what can we do about them. Again, this is very brief, but things we can do around increasing what I call lifestyle interventions around fluids, salts. I know compression garments, some people love them, some people hate them. Some people find the energy of putting them on and taking them off uses up more energy than the benefits they give. But the positioning bit, I think, is one that is greatly underestimated. And changing the position that you do things in, but also standing slowly. So if you are sitting in your chair, squeezing your toes, pumping your feet before you start to try and stand up, rather than trying to stand up, give your body a chance to catch up with you before you stand up. And also don't discount medication, because medication can help. And although I'm a physio, we don't traditionally prescribe, I do think there is absolutely a role for prescribing. One last thing I wanted to touch on is a recovery plan. And this is something that we've worked on quite a lot. And this proforma was designed by one of our patients, but it's about saying we recognise that it is a fluctuating condition, and there will be days that aren't so great. So what are we going to do about it? And it's about recognising and saying what are the things that work or help, and how do we basically plan ahead for them. So if there's particular things that you find helpful, have you got a pack with those that they sit in? If you find ibuprofen or sort of IBS or something like that, the medication, have it in a stash so that if it flares, you've got it. And actually, going back again to Norway, I think if visible is starting to identify when you're starting to crash, then you've got your pack, you can intervene. We're starting to actually help manage our symptoms really well. So I also wanted to mention severe ME and long COVID, because I think that's really important. Probably a lot of the things I've talked about are really quite easy to think about, or not easy, but more straightforward to think about how we could implement them with somebody who's mild to moderate, but a bit harder if you're in that very severe bedbound hypersensitive. And certainly any service should be looking at that around doing no harm. I think we have a big role that is underestimated around comfort and positioning for somebody who's in bed all the time, how to support them to be able to sit up, and passive movement. I always get asked, should we be doing passive movement? Well, only if it's tolerated, because actually that can make it worse. And we're all about, it's just about pacing. What can we strip out to stop that stimulus? And a lot of that is around the environment and how we can adapt it. And some of you may have seen our one pager, and again, it's a bit about that role about how do we advocate and educate. I would say if you're going to see anybody, print this off from our page, and then also have a think yourself about the things that you would like a clinician to do that might be able to help. One of the things that was really impressive in Norway at the conference was they actually had beds at the back of the hall, so people could lie down in their bed and still participate in the conference. And wouldn't it be great if you had to go to hospital, if you could sit in a waiting room where you had that? So there's lots of things, but also with severe, what are we doing about our clothes, our perfume, the noise that we make when we walk into a room, all of those things. The number of questions that we ask, what information can we send in advance? Okay, cantering through. I want to talk a little bit now about service provisions. This is bringing in a bit of the sort of what I do in my day job. And we often hear about commissioning and what is commissioning and how do we do it? Well, this is the commissioning wheel on the right-hand side, which is a little bit jargonistic, but it's really about how do we work out what the needs of our population are and how do we set priorities, plan it, and then importantly, I think around procuring those services or buying those services from a provider, and equally important around monitoring quality. Since 2022, our local services have been planned by ICBs, Integrated Care Boards, who set those priorities. And there are 40 something, I want to say, in England. However, we are massively financially challenged, and if you've followed anything NHS-wise, you'll know that they're getting rid of ICBs or they're decimating ICBs. Our local ICB has been asked to make 63% cuts, so that's a big cut. So what they will actually be doing is going to change, and what the expectations of will change. So kind of need to just keep an eye on that. So I'm talking with a bit of the as is, but I think it will apply in the future. And actually, the how and what we do around commissioning, I don't think should change. We do have a challenge in that as we get older and we live with more complex conditions, so something like our long-term conditions like ME, long COVID, frailty, they're becoming more and more common. But yet here in the NHS, we're very good at saying, go and see your cardiologist or have an appointment with urology, or rather than looking, and I suspect some of you will have been through a lot of services, and actually probably what happens is what they give you in one service has an effect on something else that you end up then going to see somebody else. And so it does create barriers, and it also means that you're sort of bounced around a little bit as you go. This is just a very high level summary because I just wanted to touch on it and say we know that there's massive variety in the long COVID services across the country. There's variety within ICBs as well as across ICBs, and also a variety of different models. And this is information that came from the stock take, and I think what people, there was quite a lot of lacking in data. So really how robust and what are they doing? This is just a very high level. And this is also very high level, and it's still work in progress from colleagues who are in the room. I just wanted to summarise it because actually it says pretty much the same as the long COVID one, is that there's variation, but worse in some ways is that we've got people who don't really know about PEM, who are still treating with outdated modalities, and also there's no quality assurance and no national rating. And more importantly, that people are describing it as unsafe. So what should co-designing, and this is the ideal. So we know that if people have a better experience, that it correlates directly with better outcomes. That's not just around ME, that's across the board. So how should we be working with patients and carers and recognizing that to support it? Well, I think it's preaching to the converted in some ways, aren't I? It's about recognizing that lived experience and involving people in service planning and making sure those care pathways reflect real life. It's no use having an appointment in 6 months' time, follow-up appointment in 6 months' time if your flare is right here, right now. You want to know how to manage it right here, right now. And that shared decision making is so important. And I think Brian has already been to talk to the group. So some of you may have heard Brian Hughes, who also presented in Norway. And this is a freedom of information that was done in 2021, but basically he said that clinics weren't actually reporting treatment harms. They didn't track anybody who dropped out. And so therefore really reinforces around what does a good service look like? It needs to talk to the people who aren't there and do start and then drop out, as well as the people for whom it works for. And in Norway, they presented FunCap. Some of you may have come across FunCap before, but I think it's a great questionnaire because it doesn't just say, can you do it? It says, what is the impact of doing something? Because a lot of you probably say, yeah, I can do it, but then I won't be able to get out of bed tomorrow or the day after. So the way the questionnaire is designed, it asks, A, can you physically do something? And B, about the impact it has. And you can see those questions in the middle. So it's absolutely something that really should be, I think, included in any service, should be looking at these patient level outcomes to see whether they are having a knock-on effect. I think there's a lot of people who probably go, they were fine when they were in my clinic, but then to ignore the fact that 2 days later they were in bed. So what should a good service do? It shouldn't do any of this, but we know that's still happening. And this was another talk that Brian gave in Norway. And I think if you absolutely want to, if you only want to listen to one of the talks, Brian's is the one to listen to, because he talked about how even when you have a guideline, why things still don't get into place. And there's all these things around resistance from people who've been invested in it before, to decision making around medics. It's totally fascinating, but it just shows that actually it's really complicated. It's not enough to say you need to write a guideline. And I actually think that's something where patient groups can really help, because you can do that sort of campaigning bit that needs to happen behind. So what I learned was that there were some massive similarities. I've tried to share some of it. There was so much I couldn't share all of it, but that there were massive similarities in how ME was understood and underfunded. But also there were over 250 healthcare professionals in the room from across Norway, which I thought was incredible. Doctors, GPs, physios, who all wanted to learn about how to treat ME and long COVID. So it was really quite impressive, and felt quite privileged to be there. The research is starting to align with what we've been saying for a long time about what works. So that's great to have that. And in some cases, it's grassroots innovation that is leading, and in some ways visible. I'm seeing there's a lot of chat, which I will answer about a bit later on. And from my particular presentation, the cognitive pacing one was the slide I put up was the one where everybody picked up their phone and took a photo. So I think that was clearly something that people were interested on. And the 3 ladies who I can see on my screen are all nodding. So I'm going to take that as agreement. Here's the people who presented, and here's the link to their YouTube channel where they've said they will be sharing the presentations this week. I'm not even going to try and pronounce it because it's quite complicated. The majority of the presentations, some of them are in Norwegian, but the majority of them are in English, and the Norwegian ones have English slides. But David Petrino, David Sistrom, myself, Carmen and Rob Burst and Brian Hughes all presented in English. So so don't be put off by the first 1 or 2 that might be in Norwegian, was my point. So what next? I think changing services means about asking some of the right questions. Thank you for the person who's put the link in. And I think it's about being specific and asking about PEM and people's understanding of PEM and pacing, and asking, is it physician-led, multidisciplinary, outcome measured? What was the input for home? Because we know that's a big cohort that get missed, and how are people living with ME involved in that design, and ongoing evaluation. And I think there's a big push around transparent reporting and what patient experience measures are being used. And so I just tried to summarize all of that into one slide to say that I think there are new approaches coming through. It really felt like a shift in approach. It really felt quite positive. There was, which I think we need to hear with those of us who've been involved and been sort of been banging our heads against the wall for a while. It definitely felt like a bit of a shift in the room, which was fantastic to see. And I think I would say it is okay to challenge professionals. I certainly, if somebody comes and talks to me about something, I welcome it, because it means I can have a discussion about what they know. And quite often they teach me something new as well. And hopefully I've given you a few things about managing function to think about as well. With my Frailty Academy hat on, whenever I do any teaching and education, one of the things we like to say to people is, what might you do differently as a result of today? And that might be something you might take away yourself to do for yourself around how you look after your own condition. Or it might be that you decide you want to link in with somebody else and say, right, we're going to ask our local clinic, do they use FunCap? Could they use FunCap? So there are lots of different things. So, and I recognise that I'm dealing with, saw somebody is saying they're getting tired, recognise dealing with people whose energy is quite limited. And so again, please choose something that that is relevant for you and where you're at. Here's our website. You can find our email address on our website. We have a page specific for people living with ME. We also want to have for parents and for carers, which you might want to direct other people to if that's helpful. We have our book, which is in small print, but you can buy it as an e-version, which might help because the small print is quite hard to read. And I'm going to stop sharing my screen, and pause for questions.
Okay, welcome back, everybody. And what I'm going to do is the interesting challenge of trying to capture some, but I won't manage all of the questions that have been put in the online chat. If anybody here has got a question as well, it would need to be very, very short, because we've got an awful lot to get through. I'm hoping we're not going to be more than 15 minutes, because that's a kind of about a maximum amount of time that I think is reasonable. So, Michelle, that was a phenomenal tour of the whole field, and really, really appreciate that. So I'm going to start off by, I've kind of themed these questions. So some of them are not exactly how they were answered asked in the chat. So I hope you'll forgive me, but that will hopefully allow us to get through the areas that have been raised and covered. You talked absolutely superbly about cognitive PEM and the effects of cognitive exertion, and therefore its impact on sleep. And certainly I know plenty of people where that just starts to go one way and then it goes worse and worse and worse and worse and worse. You know, there are people who are very severely affected, for whom their entire sort of diurnal rhythm, their sleep pattern is absolutely upside down. For thinking about cognitive time, I'm just wondering whether you've got any thoughts and tips. I want to ask you about 3 or 4 questions, because we've got this tricky thing of swapping the microphone feeds from one person to another. So it's not easy to go to and fro as a straightforward conversation. So thinking of cognitive time, have you got any thoughts about managing screen time? Because the more people are at home, the more people are online. And I'm amazed that some people are spending huge amounts of time online, and it must be actually really, really challenging to manage that, and that can have its impacts in the way that you've described. So screen time is one thing. There was a question in the chat about apps. There are a number of different apps. Obviously, Visible seems to be the one that's most known. You can get a free version, but most people find the armband useful, and that costs money. A number of people are trying to get the NHS to pay for it, but that's not happened yet. This question about red light devices and whether that sorry, your face makes you look as though you don't know. Anyway, if you know anything about red light devices, that's great. Using alarms as a kind of management for cognitive exertion. And also, I mean, in our household, we used to put 5-minute alarms on for anybody visiting, because that was as long as we thought was about right. So a set of things then about cognitive impairment. Over to you.
Okay, gosh, there's a lot in there, isn't there? And I will try and sort of summarize them. I have also tried to go through and answer some of the questions directly in the chat, and I will try and finish them off as we go. I think you're absolutely right about screen time, and I do feel slightly the irony of sharing a lot of information in a short period of time and talking about pacing and cognitive pacing is not lost on me. But I think it's really difficult because screen time and using the internet is often a way that a lot of people, it is their connection and that sort of they're isolated, and otherwise they're isolated. So I think some of the principles will still apply that I talked about being sort of managing the time that you're doing it, and rather than perhaps, if we take an example, and I'm just picking any idea, rather than spending 2 hours in one go, can you spend 4 lots of 30 minutes, or whatever your time span is, to make sure that you don't trigger your PEM. So breaking it into the small chunks that we talked about. The other thing I think that is really important for screen time is around positioning. And thinking about what position you're in when you are doing your screen time. So if you are sitting, can you prop your legs up? Because all these things reduce the effort on your circulation, which make it easier for you to be able to do it for longer. So it's around reducing the load and reducing the energy demand. Can you lie down and do it? But if you're lying down and doing it and you're having to hold the screen up with your hands, that is not so great. And great to see somebody's just changed their position immediately online. So I think it's about just trying to make sure, thinking about positioning, thinking about what you can support, how you can support yourself, so that in a good chair, so that your back is supported, so that your neck is supported, so that you've got an armrest, making sure that you're in a, posturally correct, which is physios we love. Legs up, exactly, fantastic. But also setting those alarms, just like you described, setting your alarm for like 5-minute stays for people in the house, but equally to be strict with yourself around the amount of time that you are doing something. And that's hard if you're enjoying something. But you kind of we need to remember this is about longer term rather than just the here and now, which is, it's a tough lesson to learn, isn't it? But it's kind of something that we have to flip how we thinking. App-wise, Visible is the one that, so Visible was co-designed by people with long COVID and ME, so it is set up to be for people, not, whereas the other apps are all set up for around healthy people and using it. So I think that's the important distinction. But recognizing that there's a price cost. Some people use the body battery on their Garmin watches, Fitbit, all of them you can use to a lesser or a, there are different approaches that you can use on it. I am going to share a top secret. It's not top secret, but I'll probably be like drummed out of the brownies. I have had some success with getting the Visible paid app written into people's children's education and healthcare plan. So, I think there's ways that we kind of need to work through it. Yeah, I was particularly proud of that. And I think it's something that just, we kind of shows that we do need to be thinking about these things in a different way. Our intervention for this group is not the same as it might be for a traditional approach to medicine. So we talked a bit about apps, talked about Visible. Some of the other devices have their own, and setting alarms. Red light therapy, I know nothing about. That was my face when I pulled on it, was I knew there would be a question that I didn't know very much about. So can't answer, but again, we'll take that away as something to go and look at. That I think was all, have I covered all the cognitive bits that you talked about there?
I noticed in the online chat, Suresh actually does know something about the red light, but anyway,
Absolutely.
if you can post a link or anything else, that would be brilliant.
Amazing.
So a proposal as well to use Access to Work to ask
Yeah,
for the
nice.
Visible app as well. I don't know whether anybody's had any success doing that. Right, my next kind of group of questions are about commissioning, which is brilliant that you've talked to us about commissioning. Thank you so much. There's questions which are about how many healthcare practitioners do not even know about PEM, have never heard of PEM, post-exertional malaise, do not screen for PEM, and really can even be quite resistant to kind of patients telling them how to do their job. So raising the whole profile of PEM and how Physios Remy and others are currently doing that, and how we might do that as well. ICBs, with the kind of demise of ICBs and the mega cuts they're doing, you know, what does the future hold for us? You mentioned FunCap, which is a functional assessment, I don't know what the C and the P stand for, questionnaire. And are there any examples of that being used in the NHS? And if not, is that something we should be looking at, trying to promote? So that's something we'd certainly be keen to promote with our local commissioners. And then a question as well, which is very relevant to me because I'm seeing somebody next week, but the NHS services that are still promoting the lightning process and other very harmful brain training or any sort of programs which are based on reframing your illness beliefs, which are just, we know to be so incredibly harmful. But as you pointed out so eloquently, the clinics are not recording any harm because there's no kind of yellow card system to do that. So a set of things really about kind of commissioning good quality services, and any thoughts about what we can do locally. And there's lots of people from lots of different local groups who are online today.
Yeah, great. And Julie has just put something in the chat, and that's kind of what I was just going to say. So the one pager that I shared the picture from, we used as a way for people living with ME to be able to kind of help in our quest, if you like, because we've equally found resistance when we've been trying to talk to people. But most of us are pretty reasonable. And so by putting something in front of them, it kind of does make, if somebody brought it to me, I would be going, oh, okay, better read this, better see what they're talking about. So that's a sort of practical thing. And what we are also keen is to say, take it to anybody that you see. I mean, I think that could be actually adapted for any encounter with a health professional, not just physio specific, because that's kind of what you need from any health professional, is them not to spend, you know, your limited energy talking for 2 hours about your, you know, your previous medical history. You want them to talk about the symptom that is relevant to you here and now, and that there may be other ways they could get that. So I think having to think about that one pager. I also think I'm slightly militant that if somebody isn't prepared to think about it, I would go and find a different one, or think about opportunities to use people like pals in an organisation and to share, you know, to use it as an opportunity. We do unfortunately have to advocate and to educate as we go, so that's an opportunity. The FunCap, most services when they're commissioned should have some sort of, they call it, we talk about PROMs and PREMs, which are patient reported outcome measures and experience measures. And I think it's a great one to be saying to your local service, are you using it? I don't know off the top of my head which services are using it, but we're using it in our clinical trials, in our research trials that we're doing. So it's definitely usable, and there's 2 different versions, and it's, as I said, it's being patient-led, patient-tested, so it's quite user-friendly. And the other question somebody asked, which is kind of linked around this, and I just wanted to pick up, was around if you're going to like POTS clinic, and it's a bit like what I talked about with fibromyalgia, and if they're not paying attention to PEM, in my view, it's quite simple. PEM trumps everything. And whether that's going for POTS, whether it's going to see somebody about your ingrowing toenail, whatever it is, that's what we need to factor in. And we have been having conversations with the Chartered Society of Physiotherapy about how we can champion this more. How we can share and try and get more physios to do even just the basic online training with all its limitations, but at least it is exposing people to understanding what PEM is. So I think there's a lot of work that we still have to do to educate people, and it's to educate people that this is a comorbidity that people live with, and whatever they're coming to see you with, you need to think about it. So even if they're coming to talk to you about the flu or your toenail, you still got to consider your PEM, and I think that's the bit that's quite hard for us as professionals to get our head around. Great feedback about FunCap. We aren't recruiting for any more trials at the moment, but watch out on our website. I'm trying to read the questions as I'm going. I think that was all of those, wasn't it, around commissioning?
Okay, thank you very much. Yeah, we did have a question about mandatory training. I know the NHS have now just released their third module, 1, 2, and 3. My understanding is that the training is not mandatory, but is at least there. Modules 2 and 3 we've not seen because they're somehow secret. But there are a growing number of kind of education programs out there. What's great news, I don't know whether everybody is aware, but the General Medical Council have now got MECFS as on their kind of map of learning for medical students. And we argued that, well, that's great, but actually if you don't put exam questions in, nobody will do that work, and they apparently have a little bank of exam questions. So that's warning to anybody who's coming through the system now that they need to gen up on it, and that would be really good. I've got a number of kind of biomedical physical questions really. One is about comments about the link between hypermobility and ME long COVID. One is about whether the hand squeeze grip that the UK Biobank people, they did a talk for us actually, which was about the hand squeeze grip as well, about being one of the biomarker potentials. There was a question about how people progress through the 4 levels of mild to moderate, severe to very severe. Does it follow that pathway? Is it a kind of, is it a one-way ticket? How is it? And then there was also a sort of comment question really, which is you made reference to the recovery plan.
Yes.
You've got a kind of my recovery plan, and comments from Kate about recovery. Are you sure? Should it not be a management plan rather than a recovery? Because that's a word that we're really, really uncomfortable with because of the false expectations that go along with that. So
yep.
Great. Those 4.
Thank you. And I'd actually written that when I scanned through, I'd written that as my sort of what I wanted to say, and say it's a really good point. Just to say that was designed by people living with ME, that's what they put forward. So, but we should have picked it up. You're absolutely right, and I will change it moving forward. So thank you for that. Hypermobility, yes, again, lots of links, and I think. There's so much that I could have shared from the talk in Norway, and apologies for not having set the context around Norway when I started as well. I saw that question in the chat, but actually I think we are starting to see some of those links between some of these, we call them comorbidities, that conditions that exist along together, and I think hypermobility is definitely one of those. I think what we do with it clinically would depend on the person in front of you as well. So how traditionally, if you had hypermobility without ME and without any PEM, you would probably look at some strengthening type of exercises so that the muscles would support the joint. But that's maybe not so appropriate within people who've also got ME. Grip strength, I find, is totally fascinating. I think and how can just squeezing show you is a real thing for me. I think the bit, I suppose, from a grip strength perspective is there's a lot of different things that we can use grip strength for, and that we know it would be reduced in. And so is it discrete enough to be a biomarker? Probably not. So do you remember I showed that slide quite early on where there was that distinction between there was clear separation between the normals and the people with long COVID and ME. That's what we're looking for, being able to say you sit either side of a line. And I think there's a lot of variation in grip strength for conditions other than this, but it certainly is something that can give us an indication. Absolutely. And deterioration. I was just trying to read my own writing. I wrote down what you said and I was trying to read the deterioration. So I don't think certainly there doesn't seem to be a clear pattern, and that you can say everybody deteriorates at a particular rate or everybody will deteriorate at a particular rate. I think the one thing that I think is important is wherever possible to try and minimize PEM, because we know that's putting that overload, that it's asking our bodies to work over and above where we're at. That's the only thing I think that we can say. We can't say if you put yourself in PEM 3 times a week, it's more likely to make you to deteriorate. And I think there is so much that we still don't know. If you look at things like multiple sclerosis, we're starting to see that there are different forms. There are remitting forms. There are people that deteriorate. I wouldn't be surprised if we don't start to find the different subgroups in ME, but we're not that sophisticated yet with our research, is my answer to that. And I'm trying to see whether there's anything else. Good point about grip strength not being correlated with PEM. I think it's more around the fact that grip strength, people with ME tend to have a slightly reduced grip strength compared with the normal population, rather than it happening when you're in PEM. So yes, that's probably answering those ones.
Thank you. Okay. Yeah, my understanding of the hand squeeze is that the normal, if they are population, can do it twice, equal strength, and that people with ME/CFS can do it once at normal strength, and the time it starts to get weaker and weaker.
Weaker as you go.
It's not PEM, it's just a reducing ability to repeat. But so anyway, a couple more bits really. One is for me, which is about, people talk quite a bit about oxygen therapy, and I just wonder whether you've got any comments about that. There's a question about recruitment for trials. Certainly people amongst population in Sheffield have been amazing about contributing to research trials, and obviously we work closely with Caroline Dalton here, which is fantastic. And then I think I know we haven't covered everything in absolute detail, but I think we've kind of covered all the main themes that I feel I've picked up. So given the time, I think those might be the last 2 questions. And then I just want to say closing remarks.
Can you just remind me of the first one? Sorry, I didn't write it down. My cognitive overload is well and truly
Oxygen.
Now. Oxygen, yes. I think we don't know about oxygen, and that question was asked as well in Norway by to David Systrom, who does a lot of stuff around cardiovascular stuff, and his answer was we don't know. And some people seem to respond to it, some people might not, but we don't really know enough to be able to make any sort of informed statement about it at the moment. Clinical trials. We're doing a transcutaneous auricular vagal nerve stimulation trial at the moment, but recruitment has finished on it. And there was, interestingly, a conversation between us as researchers in Norway around how we might sort of look at getting a registry, if you like, of people who would be interested. And certainly what I was surprised about was to see people who were quite interested in really detailed technical molecular biopsy, who were wanting to know what what patients were saying were the things that they were found worked and didn't work, because they then wanted to go off and do the research that proved what might be going on and why it didn't work. So I would say keep talking and asking about the things that you know about that work, and let's try and get the evidence to see it support it, a bit like we saw with the sleep and the heart rate variability.
Can I say the most enormous thank you to you, Michelle? It's great both that you brought your expertise as a physio and the work with Physios for ME, the expertise in relation to commissioning and transformation, and also you've been the kind of conduit of messages back from Norway. So that's been an incredibly full and detailed session. We've covered an awful lot. Really appreciate you contributing that and helping us through our afternoon. And a big, big, big thank you.